The objectives are shown on the slide right now. No disclosures. This talk will be a little bit kidney-centric because, like everything else in transplantation, a lot of our data comes from the kidney transplant population, given the volume of transplants that you guys do. So when it comes to kidney transplantation, we know that cardiovascular mortality in hemodialysis patients before patients get their transplant is estimated to be 10 to 20 times higher than the general population. I mean, that is a staggering number. And with improved survival in kidney transplantation, we do get improvement in cardiovascular outcomes compared to being on renal replacement therapy. And that's really irrespective of what the cardiovascular risk is, what the diabetes status is, what the age of the patient recipient is, what the obesity status is, whether the recipients receive a marginal donor versus a good donor. And this is applicable to any kind of transplant organ. So obviously patients who get a heart transplant, for instance, will do better than those who do not. And usually those patients die with cardiovascular disease, of course. But I think even in the liver patients and in the lung patients, we do see a lot of significant issues with cardiovascular morbidity and mortality that is associated in that patient population. Now, I am not an expert when it comes to outcomes in kidney transplants in general, but what we have seen, just like other organ systems, is that over the last decades, we have had considerable improvement in outcomes in terms of survival of both the graft, which is shown here, and a lot of the improvement in outcomes, just like many of the other organ groups, I think, are occurring earlier on. So whereas before people were, the grafts or patients in general were being lost early in the first year or so, now we're seeing much better improved outcomes in the short term, probably better immune suppression and better patient selection. But what's a little bit disappointing, and I think that's the point of this slide, is that when you look at longer term outcomes, we're still not showing significant improvement 20 or 30 years down the line, which is, the question is, why? How can we make it better? Now, interestingly, when you look at the reasons for why patients die post-kidney transplant, the outcome will depend on what the etiology of the kidney dysfunction is. And I think this speaks volumes to what the risk factors at play going into the transplantation are. So what you can see here is that in the purple and the green, patients who have diabetes and hypertension at baseline that cause their chronic kidney disease and end-stage renal failure tend to do worse than those who have a primary glomerular or kidney problem. And I think once again, highlighting the fact and the importance of risk factors. Now, when you look at lung transplant, just to make it less kidney-centric here, what we have seen over time, same thing as with kidneys, that as we have moved from initially the blue period to the green and the red, improvement in survival in patients post-transplantation. And what's a little bit sobering, and I always, whenever I see this graph, I'm reminded of the fact that the median survival of patients, is only about 6 years post lung transplant. For hearts, it's a little bit better. We're looking at 10 years or so, but nonetheless, not as good as kidney transplantation, that's for sure. So, what are the keys to success in terms of transplantation outcomes? Well, if we're thinking about graft survival, which is important for kidneys, of course, it's going to be reducing rejection, and what we want to see is improved 1 year survival, which is associated with longer term survival of both the graft and the patient. And when we look at patient survival in general, what is crucial in patients who have transplant is improving their cardiovascular risks, because cardiovascular disease is one of the leading causes of mortality post transplantation, and one of the leading causes of premature death. And the other ones that we always talk about, of course, are malignancy, which I will not touch upon in this discussion. So what are the important late risks that are associated in this patient population? Well, I think there are donor factors that lead to poor outcomes. And some of these may include cardiovascular disease, malignancy, and infection. But there's also issues relating to late graft loss, and this would include chronic allograft vasculopathy, nephropathy, whatever else it may be in the different organ groups. There could be subclinical or clinical acute cellular rejection or acute antibody-mediated rejection that James will talk about later on today. And of course, infections, whether it's viral or other, that cause demise of the organ. When we look at death and loss of graft, on the left side, we see that the reason why grafts are lost in kidneys, at least, the majority of the time is due to death. So the first cause or reason why the graft fails is because patients die and then the graft fails. But there are, of course, other causes like non-compliance, which we all see of, unfortunately, in our different disciplines. There is chronic rejection issues. There is recurrence of the primary disease that caused the initial insult to cause the kidneys to fail. And then when we look at this yellow pie or a slice of pie, which is a big slice of pie here, and we break it down to, well, why are people dying prematurely? What we can see is that cardiovascular disease causes about 40% of deaths in patients who die before their graft fails. Other causes include infections and malignancies. And so I think this highlights, once again, the importance of cardiovascular disease and longer-term outcomes of kidney transplants. Now, when we look at lung transplantation, it's a little bit of a different story. Perhaps it's because there's different risk factors at play going into the lung transplantation, and usually these tend to be younger recipients as well. But in the blue is the cardiovascular causes of death. And infections are in green, and in the teal color is graft failure. And what you can see is that early on in the first 30 days, people die mostly or predominantly due to either infections or graft failure. Cardiovascular mortality accounts for a smaller proportion of causes of death, but even out to 5 or 10 years, it starts peaking by 10 years, causing about 8 to 10% of deaths. Now, there's other, obliterans of the lung tissue that can occur, which causes death later on in lung transplant, which is unrelated to what the kidney folks and the heart guys and the liver guys see as well. Now, in this study that I believe is from the Netherlands, looking at about 2,000 patients, they looked at patients who received a heart transplantation, and they followed them for a long period of time, up to 20 years, as you can see here. And they wanted to see what is the cardiovascular free survival post-transplant, cardiovascular event-free survival. And so what they looked at is patients who had had a transplant, and they said, okay, well, let's look at how many of them died due to a cardiovascular death, like sudden cardiac death, for instance, how many had a non-fatal myocardial infarction, stroke, or had revascularization or vascularization of coronary occlusions. And what they saw was that when they followed patients after 10 years, we're looking at approximately 33% of patients had some sort of cardiac event. So 1 in 3 patients will develop some sort of cardiac event over a period of time. And they wanted to see, well, what predicts some of these cardiovascular events before the transplantation? Can we use anything, any markers? And what they saw was that there was a few different variables that came out as being significant in their multivariate analysis. And some of these include, not surprisingly, diabetic nephropathy as the primary etiology of the kidney dysfunction. Diabetes, claudication, a reflection of peripheral vascular disease, a previous cardiac event, like an MI, for instance, or heart failure, time on dialysis. And this seems to come out over and over again. So the longer you are on dialysis going into the transplant, the higher risk you will be for developing a cardiovascular event post-transplantation. And history of CVA, recipient age, so the older you are, the more likely you will develop an event later on as well. I think these are the main ones that showed up. And so there's a clear relationship between chronic kidney disease and cardiovascular disease, where unfortunately you all know this, that chronic kidney disease is a risk factor for cardiovascular disease, and conversely, cardiovascular disease ends up being a risk factor for progression of chronic kidney disease, and that's irrespective of whether there is transplantation or not. And when you add transplant into the mix, we have to think about non-traditional cardiovascular risk factors. So whenever we think about cardiovascular risk, we're thinking about male sex, age over 65, smoking status, diabetes, hypertension, dyslipidemia, family history. But then there's these other non-traditional cardiovascular risk factors that are very unique to the transplant patient or unique to the kidney patients, chronic kidney disease patients, that can cause premature cardiovascular disease and cerebrovascular disease, which can feed back onto the kidneys and causing worsening kidney function and proteinuria and other things that can decrease the survival of the graft and decrease patient survival as well. And so, on the left side, we have the traditional risk factors that I sort of mentioned some of, LDL and HDL and hypertension, menopausal activity, physical activity, of course, as well would be included in here, LVH. But there are, in chronic kidney disease patients and transplant recipients as well, there are these non-traditional risk factors. So anemia, volume overload state, abnormal mineral metabolism, and electrolyte imbalances and albuminuria are things that have been associated with worse outcomes, for instance. And when you go further into the non-traditional risk factors in the transplanted patients, and this is applicable to all the organs, including patients at ICU with heart transplantation, if you have delayed graft function, if you have post-transplant diabetes, previous acute rejections, and some of the immune suppression medications that we use can worsen the cardiometabolic risk factors and cause premature coronary disease and cardiovascular events. And so the combination of donor factors, recipient factors, immunological factors, and non-immunological factors, as mentioned, like medications, for instance, they all have an influence on GFR, your kidney function, but will also influence directly lipid status, your diabetes status, your hypertension status, and ventricular hypertrophy, which can occur, which causes abnormalities in myocardial function. And these can cause two different cardiovascular events, such as arrhythmias, heart failure, coronary disease, and even valvular heart disease and premature aortic stenosis and mitral stenosis, for instance. And these in the long term can cause cardiovascular mortality as well. So I think one of the key things to understand is that patients with chronic kidney disease benefit as much as non-chronic kidney disease patients with appropriate medications and therapies, if not more, because of their increased risk. And I think this would be, I would extend this to not just chronic kidney disease, but the transplanted patient in general as well. What we see here is that in the dotted lines are patients who are on hemodialysis, and these are patients who are Caucasian versus Black, males and females. And what you can see is that the risk of dying when you're on dialysis, irrespective of age, is so much higher than the risk of dying if you are a healthy, relatively healthy in quotation mark, GP. We know that physicians are not healthy sometimes. But when you look at the transplanted patients, their mortality is not normal, especially in the younger patients. They're about 10 times higher than the general population. And as you get to older age, not surprisingly, if you're 74 and you get a transplant, then, well, you only have so many years to live anyway. So your mortality may not increase, but your quality of life might improve significantly. And so I think this shows the discrepancy that we have and the higher risk that we have in those who are not only on dialysis, but those who receive a transplant for their chronic kidney disease. And the majority of deaths, as mentioned before, are going to be due to sudden cardiac or arrhythmic deaths, so cardiovascular causes of mortality. Now, interestingly enough, and I think this is applicable to different organ groups as well, but more so highlighting the role of kidney function and cardiovascular events, this study looked at 48,000 patients who received a kidney transplant, and they broke them down into creatinine at 1 year post-transplant. So these are, by 1 year, the kidney function should be stabilized, and where patients are going to be. And what you can see here is that patients who had low creatinine, these are measured in the US units, so it's less than 1.3, is approximately 110, 115, have the best survival, not surprisingly. But as the level or degree of kidney function worsens, as the GFR decreases or the creatinine increases, what you can see is that there's a clear relationship between worsening kidney function and cardiovascular death subsequently, and this is out to 10 years post-transplant. And similarly enough, when you look at GFR, another measure, of course, of kidney function, there's a graded and independent relationship between estimated glomerular filtration rate and cardiovascular disease outcomes. And so once again, that's death, MI, revascularization, and stroke, such that, as the GFR decreases, if it's less than 30, you have almost twice the risk of dying or having a cardiovascular event compared to if you have a normal GFR post-transplantation. And so what are these cardiovascular complications that people are getting? Well, heart failure is something that, of course, I have an interest in, but that's one of the things. You have arrhythmias, MI, stroke, and deaths. And 70% of dialysis patients will have some sort of abnormalities in their cardiac function or structure. So they will have left ventricular hypertrophy, they will have LV dysfunction, or they'll have atrial enlargement or something like that, which is a reflection of the pressure and volume overload secondary to chronic dialysis and fluid retention. Now, interestingly enough, transplantation can improve heart function. In the study that looked at 103 patients in the States, in Maryland, they looked at all the patients who had a low EF at baseline going into their kidney transplant. So all of them had an EF of less than 40%. And what you can see here is that irrespective of coronary disease status, previous CABG, previous PCI, or diabetes or no diabetes, the baseline EF was approximately 30% on average pre-transplant. And post-transplant, invariably, the majority of patients had improvement in their LV function to an average of about 50%. And so LV dysfunction pre-transplant does not mean that it will be sustained post-transplantation. Now, interestingly enough, when they looked at patients who had group 1, which is post-transplant EF more than 50, group 2, which is marginal improvement in LV function, where the post-transplant EF was between 40 and 50, and group 3, which had ongoing severe LV dysfunction or moderate severe LV dysfunction, what we see is that there's a graded response or a graded mortality change. So they're showing that those who had an improvement in LV function post-transplant had a significant improvement in outcomes compared to those who had minimal or no improvement in LV function post-transplant, and likely a reflection of how advanced the cardiovascular disease was at the time of transplantation. Obviously, if there's recovery of LV function, that implies that most of the LV dysfunction that was there was due to the kidney disease. And sometimes it's difficult to predict which patients will improve their LV function or not. But what they tried to do is look at predictors of improvement. And when they did their multivariable analysis, what you can see is that these numbers kind of odds ratio, where higher odds ratio usually implies that you will have a higher likelihood of improving your LV function. There's a few that show up as being high, but they're not significant. The p-values are greater than 0.05. But the only one that turns out to be predictive of change or improvement in LV function is time on dialysis. So the longer you are on dialysis, once again, the less likely you are to improve your LV function. And so maybe we should try to minimize dialysis wait times if we can in these patients. We need more organs. And so that I think that's the bottom line is the shorter you are on dialysis, the better your LV function is going to be, the less your mortality most likely is going to be as well post-transplantation. Now, interestingly, once again, when you look at the cardiovascular risk profile of the kidney transplant recipients, by 1 year, 50 to 90% of patients post-transplant will have hypertension. 30 to 40% of them who did not have diabetes will develop diabetes. 50% will have dyslipidemias. A substantial proportion of patients will have abnormal kidney function post-transplantation. And similarly, when you look at the ISHLT registry, which is part of the lung transplant group, within 5 years, what you see here, I got the wrong slide because this is looking at the re-transplants, but even when you look at the new transplants, we have about a 50% risk of developing hypertension at 1 year and about 80% at 5 years. When you look at renal dysfunction, about 50% at 5 years. Hyperlipidemia, 50% at 5 years. Diabetes, 34% at 5 years. So once again, not limited to the kidney transplant recipients, but we see this in our organ as well. Our patients get dyslipidemia, they get diabetes, they get hypertension, which leads to the untoward benefits of immune suppression. So how can we assess cardiovascular risk? Well, in cardiology, we like to use something called the Framingham risk score or other risk scores to evaluate the risk of developing an MI or death in the subsequent 5 or 10 or 20 years. And the Framingham risk score is very good in the average individual, but there's not a lot of risk scores that have been developed for patients who have had a transplant. Now, there's one group that looked at patients. This is from the ALERT trial, which it was a fluvastatin trial in kidney transplantation. And they wanted to see, can you develop a risk score? Can you predict who's going to develop a cardiovascular event? And so they came up with 7 variables for that if you have a combination of one or more, then you're at higher risk. And of course, the more of these you have, the higher the risk of developing a cardiovascular event. And so for cardiovascular events, i.e. death, MI, or revascularization, the variables that turned out to be significant were older age, not surprising, history of cardiovascular heart disease, previous smoking, current smoker, creatinine, so the higher it is, the worse the outcome, diabetes with a high hazard ratio, high LDL, and the number of transplants. So if you're a redo transplant, then your risk of developing cardiovascular events is going to be even higher. When they looked at mortality, then we're back to the same kind of variables, minus 1. So predicting death will be age, presence of coronary disease, previous smoking, or current smoker is even a higher risk of dying, higher creatinine, presence of diabetes, but also total time on renal replacement therapy. So this issue of the time you are on dialysis keeps coming back as being a predictor of worse outcomes in the future. And I think what's sombering is the fact that in the favorite study, so that's a study looking at folic acid for vascular protection in kidney transplant once again, what they saw at baseline is that 2/3 of the patients starting the study were not achieving target blood pressure goals of less than 130/80. About 20% have elevated cholesterol greater than 2.6. And about 1/3 of patients who had a history of coronary disease or angina were not on an antiplatelet agent. So I think we all have some room to improve how well we're treating our patients with their cardiovascular risk in order to decrease their long-term risk of developing an event. And unfortunately, and surprisingly, I have to say that with the large number of transplants that are occurring worldwide when it comes to kidney transplantation, there's very little prospective evidence that's looking at different therapies targeting cardiovascular risk in this very high risk group of patients. We know that in hearts and livers and lungs, we have less patients being transplanted on an annual basis. And so doing a high-powered study to show benefit is challenging. But hypertension, I think, is probably one of the most important targets that we have to treat in order to reduce cardiovascular risk. And obviously, a lot of patients will have pre-existing hypertension, but the general population risk factors like obesity, smoking, alcohol, and excessive salt exist in our transplant patients as well. Renal dysfunction and rejection can worsen hypertension. You can develop renal transplant artery stenosis, which hopefully is not that common. I'm not sure how common that is seen. I guess it would be surgeon and site dependent. The effect of the native kidneys on hormonal balance may also influence hypertension development. Obviously, if you have a hypertensive donor who has some glomerulosclerosis, then that might lead to recipient hypertension. And the immune suppression drugs that we use, which prolong survival of the graft in the patients, also, unfortunately, as a side effect, can cause hypertension. And hypertension is associated with worse graft survival. So the patients who do best are those whose blood pressure, systolic blood pressure, is less than 130 or less than 140. But as the blood pressure increases, what we can see is there's a definite graded response in terms of worsening mortality, or graft survival in these patients, unfortunately, such that 50% of patients who will lose their graft by 7 years if their blood pressure is extremely high, greater than 180. And it sounds like a high number, but what's also surprising is that you have about 1,000 patients out of a total of 25 or 30,000 patients who have a blood pressure of greater than 180. So that's pretty high. Only a small proportion of patients are at targets, once again, less than 130 to 140 systolic. So does treating high blood pressure result in improved patient outcomes and graft function, or preventing graft loss? So the short answer is probably, based on kind of historical data or retrospective data. But there really haven't been enough adequately powered studies to show that that's the case. But it is likely that these high-risk patients will derive the same benefit for heart, brain, as well as for transplant kidneys. And so what therapies can we offer? Well, we can offer diuretics, hydrochlorothiazide, chlorothalidone, what have you. We can use beta blockers for heart rate control and treating coronary disease and angina. We can use alpha blockers if patients have BPH and outflow graft obstruction, or sorry, outflow obstruction in the prostate, for instance. But I think the hallmark therapies for hypertension in kidney transplant and other transplants and coronary disease in general is going to be probably your ACE inhibitors and maybe your calcium channel blockers. And so due to the fact that there's very small trials, nothing big and powered to show mortality benefit, so people have done multiple meta-analyses, so combining the results of multiple trials together to see if we can show a benefit. And this is sort of a busy slide, and I apologize, but the bottom line is, to me, is mortality here. And when you compare calcium channel blockers to placebo or treatment, you have a relative risk ratio or a relative ratio of mortality reduction of 0.75. So it looks good, but unfortunately does not meet statistical significance. And when you compare CCBs versus ACE inhibitors, I mean, the relative risk is 0.25. But look at the number of patients, 221. And when you compare ACE inhibitors to placebo, I love this one, 30 patients in one study. That's the extent of your evidence for randomized controlled trials, at least when this meta-analysis was done in 2009. And so really difficult to make strong conclusions when you have such small trials. But what did show up as being significant is that when you compare calcium channel blockers to ACE inhibitors or other therapies or placebo, calcium channel blockers come out ahead as being good for preventing graft loss with a hazard ratio of 0.75. And I think this is the meta-analysis of graft loss in these patients, and you can see a lot of trials a little bit all over the place when you look at the unity line being here, but overall just comes out significant with a confidence interval that does not cross unity. Now, ACE inhibitors and ARBs, we like using them a lot, especially the kidney folks. You guys love these drugs because they prevent progression of kidney disease in general. They have antihypertensive properties, antiproteinuric properties, and antiproliferative properties as well. And in this one retrospective study, which was published in 2006, so it's retrospective, not prospective, so it's not a randomized study, they looked at 2,000 patients who were treated with an ACE inhibitor, and there was an increase in ACE inhibition use from 9 to 47% in that period of time, with an increase in ARB use as well. And they tried to look at medications and other comorbidities to see if they could predict whether these patients who received ACEs and ARBs would derive benefit. And what they showed in this, once again, retrospective study is that patients who received an ACE inhibitor or ARB, they were less likely to die compared to those who did not receive an ACE inhibitor or ARB. So they concluded that ACE inhibitors will reduce mortality in this sort of, once again, retrospective study by 26%, 74 compared to 55. So about 19% absolute risk reduction over 10 years in mortality reduction. And similarly, when they looked at loss of graft over that period of time, and they counted death as a graft loss as well, similar kind of outcome where you get an 18% reduction over that 10-year time period. So it seems in this retrospective study that ACE inhibitors are better than no ACE inhibitors or ARBs in reducing mortality and graft loss as well. Now, there has been a systematic review of randomized trials using RAS inhibition in kidney transplantation, median follow-up at 27 months. This was published in 2007. And what they showed was that using ACE inhibitors and ACE inhibitors or angiotensin receptor blockers, the GFR goes down a little bit, which is not too surprising, of course. Hematocrit decreases, proteinuria decreases, no change in serum potassium, but not powered enough to see an effect on patient or graft survival. In this one small study published in 2013, once again, so this is after the meta-analyses were published, this only had, I think, about 60 patients, 36 in one arm, 34 in the other arm, showing a composite endpoint survival benefit to ACE inhibitors compared to placebo, as well as cardiovascular event-free survival that was significantly significant, p-values less than 0.01, 0.02. So I think there's enough evidence for me to say that patients who receive a kidney transplant should ideally be on an ACE inhibitor if they are hypertensive, because I think there is enough sort of studies and meta-analyses show a signal in that direction that there is benefit in preventing cardiovascular events and mortality as well. So diabetes is also a key risk factor for coronary disease. It is associated with
so I got the one screen.
Reduced patient survival as well as reduced graft survival.
I was just a presenter. Now I'm
histological appearances of, I'm going to turn this off. That's not helping. Histological appearances of diabetic kidney disease within 5 years of patients receiving.
So good, thanks. And thanks for pointing out.
Okay,
if you double-click on mics, that would be great, and the satellite sites. Thank you.
Okay, I see picture of myself.
Now, there's very little data on glycemic control in post-transplant patients. But what we do have is a lot of data in the non-transplanted patients. And what we know is that diabetic control, whether it's usually with oral hypoglycemics or with insulin, can result in a reduction in microvascular events, so nephropathy or ophthalmopathy or in the eyes. Maybe some benefit to preventing macrovascular disease like coronary disease and stroke, and questionable whether mortality improves if you control glycemic blood sugars a little bit better. And in this big study that followed patients out to 20 years, what they showed was that intensive glucose control did reduce the first occurrence of non-fatal MI, stroke, or death from cardiovascular disease in type 1 diabetics. But what you can see here, it takes many, many years to get that potential benefit in patients. And so I think glycemia is an important target to try to control in our patient group. Controversial as to what the target control should be, whether it's a hemoglobin A1C of 6, whether it should be 7 or higher. I think the newer data says, being too aggressive with glycemic control can cause more hypoglycemia and other side effects. So we have to be cautious, and especially when it comes to the transplant recipients, because there's very little data on glycemic controls. And I think one of the important things to target to prevent cardiovascular disease, which is more of a longer-term effect, is lipid lowering. And so in cardiology, we've been talking about lipid lowering for many, many years to prevent cardiovascular disease in moderate or high-risk patients who do not have a kidney transplant. But there is rationale for lipid lowering in chronic kidney disease as well as in transplant patients. So chronic kidney disease and end-stage renal disease patients are at increased risk of cardiovascular complications, as I highlighted earlier. CKD and end-stage renal disease patients have abnormal lipid profiles, and a lot of secondary analyses of lipid-lowering studies indicate that statin treatments improves cardiovascular outcomes in chronic kidney disease patients. And so there's one study that was done in the chronic kidney disease population, not transplant once again, that looked at patients who were not on dialysis, who had an elevated creatinine, close to 150 micromoles per liter. And if they were on dialysis, then they had to be on hemodialysis or peritoneal dialysis, age greater than 40, no history of MI or coronary revascularization. So there's no previous indication for a statin use. And what they did is they randomized patients essentially to simvastatin, ezetimibe, or placebo. And they showed that by adding a statin versus placebo with ezetimibe or ezetrol, there was a significant reduction in atherosclerotic events, 17% reduction compared to placebo. And so good evidence for using statins and ezetimibe in that patient population. Now, what about the kidney transplant recipients? I can tell you that in the heart transplant recipients, we know that statins make a difference, and I'm not going to go into that data. But in the kidney transplant recipients, in this randomized study of 2,000 kidney transplant patients, they looked at cardiovascular death, non-fatal MI, or cardiac procedures. They randomized patients to either fluvastatin, so another statin, or placebo. And what they showed was that there was a 17% relative risk reduction, so a reduction in the primary outcome, which is not significant, but a strong trend to it. But there were fewer cardiac deaths and myocardial infarctions in the treatment group. And what you can see here is that patients who were treated with fluvastatin had a significant reduction in their cholesterol level from a baseline of 180, which is almost an LDL of 4.5 or so down to almost an LDL of 3. And as you follow them over time further, it went down to even lower, an LDL of less than 2.6. In the placebo group, there's very little change in their LDL until everybody started receiving their fluvastatin at the end of the study, and then their LDLs came down as well. And what this shows was that the cardiovascular death, non-fatal MI, or primary PCI, had, when they followed patients for a longer period of time, so in the initial study, the p-value was 0.139, which is not significant, but when they looked at the extended follow-up period, the primary endpoint did turn out to be significant, p-value of 0.036, has a relative risk ratio of a 21% reduction in the combined endpoint. So I think more evidence that statins do work, I think, in reducing mortality in the kidney transplant patients, in the heart transplant patients, and I would probably extend it to other organs as well. And this is the mortality curves, but you can see that out to 5 years, not a lot of significance, but it takes a while for the effects of statins to work on reduction in atherosclerosis development. And so I'm not surprised that the events were reduced later on and not earlier on in this high-risk patient period. And so what about other risk targets? Well, obviously, there's the lifestyle stuff, physical activity, smoking, obesity. Not a lot of studies that looked at them, but I think it makes common sense that patients need to be active, they need to try to lose weight, and stop smoking as well. And so I think what should we do for our patients? We need to target a low blood pressure. The target, I don't know what we're using in Vancouver, but I would argue that it should be less than 130/80. We need to evaluate and treat lipids with a target LDL of less than 2.6. We need to deal with worsening kidney function, so maybe using ACE inhibitors and other modalities for reducing microalbuminuria, proteinuria, and reduction in kidney function. Obviously, salt and saturated fat needs to be monitored in the diet. We need to be cognizant of the importance of glycemic control to long-term outcomes, managing anemia and control calcium and phosphorus balance, and use antiplatelet therapy. And I think I got 5 minutes. So thank you very much for your attention.
Thanks, Mustafa. Does anybody have any questions from the satellite sites?
Can you comment on PCI versus CABG outcome in the renal failure or transplant patient?
Yeah, so that's a great question. So is there a difference between PCI or CABG in these patient populations? And so once again, I think there's limited numbers. We know now that in diabetics, we always argued with the surgeons, cardiologists just keep wanting to take over the surgical role of managing cardiovascular disease. And so in the CABG population, in the diabetes population, we know that based on the FREEDOM study that CABG trumps PCI for longer term outcomes. I would extend that to the diabetic kidney patient. When you look at, the ACC-AHA has a document that talks about the evidence and the recommendations for managing patients with their cardiovascular disease and cardiovascular risks. And what they recommend in that document is that we treat transplant patients just like non-transplant patients. So if they have a high risk coronary anatomy that's not amenable to PCI, if it's proximal LAD plus another vessel, if it's diabetes, or if it's LV dysfunction or left main disease, then we would recommend CABG over PCI. But it's a good question with, once again, little evidence in this specific group of patients. Other questions from satellite sites or locally? One thing I didn't talk about is the Re-Transplant evaluation, and I didn't want to get into it, but as we highlighted, with your first transplant, you're at high risk for developing these cardiovascular risks, and so I think we don't see a lot of Re-Transplant, but you guys probably see a lot more than we do in kidney, and so I think those patients who are being evaluated for Re-Transplantation, we have to be very cognizant of the extreme higher risk that's associated in this patient group. And I think we need to be very thorough with evaluating them, especially I find in the diabetics who may present, and the females as well, who have atypical presentation of cardiovascular disease or coronary atherosclerosis and angina. They might have angina equivalents and shortness of breath, which of course chronic kidney disease and a failing graft can mimic that as well. And so I think I'd be extremely cautious and and evaluate them very thoroughly before they're being considered for retransplantation.
Thanks very much, Mustafa.
All right, thank you.